Much for coming to our March Patient Voice panel on women's health. The panel is sponsored by the Office of Health Equity and Inclusion, and every month we try to feature a different patient population so that as healthcare providers or healthcare educators, we can learn about what different patient populations are looking for when they go and receive healthcare. We're thankful for AMWA, who helped us to organize this month's panel, and these students will be moderating in just a little bit. I do just want to make a couple of logistical announcements. I have two. The first is that CME credit is available. It's written on the board here, and there's also a flyer in the front to my left. And so if you are looking for CME, please do take one of those flyers and sign up for CME credit. The other announcement is that we do value the feedback that you have to provide for us. So I will be handing out paper surveys later that we would ask you to fill out before you leave. But if you prefer to fill it out online, there's a tiny URL link on the board. I'll read it to you right now just in case you can't see it. It's tinyurl.com/PV for patient voice, so PV women. So if you prefer to fill it out online on your phone or computer, laptop, tablet, please feel free to do that. So with that, okay, and I'll turn it over to our moderators.
Great, thank you so much, Dr. Chow. My name is Joanna Tomaszewski, and this is Fu Kobayashi. We're the co-presidents of AMWA, and we want to thank you all so much for being at today's Patient Voices Women's Health Seminar. We engage all of you to participate, and we're going to leave about 15 minutes at the end for any questions that you may have. I also want to thank our speakers in advance for their time and for their participation. I'm sure we're all really excited to looking forward to hearing their unique perspectives on women's health. Today's session, as Dr. Chow mentioned, is hosted in combination with AMWA and the Women in Medicine group. And our goal is to facilitate a conversation with female patients from different backgrounds and spanning the lifespan. Please also join us for future talks. On April 26th, we have the Geriatric Patient Voices, and on the 24th, the Asian American Patient Voices. And on the 14th of June is the LBGT Patient Voices, so announcements about that will be coming up. And I'm going to hand it over to Fu to introduce our speakers.
Oh, hello. All right, so starting from your guys' left, we have Dr. Joni Heman, and then we have Ashley Weitz. Oh, what's in there? Sorry, Karen Beeman, and then we have Sharon Slater. And then we have Ashley Weitz. I'm going to ask all of you to spend about 2 to 3 minutes to give us kind of a background story and tell us a little bit about yourselves. And then we're going to ask a few questions afterwards. So if we could start with Dr. Heman.
This is like the hot potato cups that we pass along. Can you hear? Does it sound like a microphone? Mm-hmm. Oh, excellent. This is the funniest thing. So I'm Joni Heman. Some of you know me from like Layers of Medicine or other interactions through the medical school. I'm the medical director for the Teen Mother and Child program at South Main Clinic. So I do a lot of women's health in that sense, but I also am a breast cancer survivor. So I've gone through lots of treatments at the Huntsman Center. And then I was asked to join this panel to give a parent perspective. I have 3 kids, 14, 12, and 8. And my 14-year-old has had a number of both medical and mental health issues, and so we've had to navigate the healthcare system with her quite a bit. And then my 2 younger children, I just have the perspective of child care, sort of, going through that with them. So if we're talking about spanning the lifetime, I have experience with that in the pediatric world as well. So that's kind of my background.
I think my advantage or can help you is the sense that I grew up with doctors. I watched things change because I'm an old bird. And I also work with intermountain therapy animals, and I actually come here for your stress management. And so I have a chance to understand a little bit of what's going on in your school and what you're learning, which I'm absolutely thrilled because I see a lot of things changing. I have my own illness, which is I have a mycobacteriums in my lungs and spent 2 years trying to figure out what was wrong and had many physicians and finally came to an ideal situation, which we'll talk about later. And I have 2 children, one who's 38 and one who is 36. My 38-year-old is a female. The thing that I'm learning about from her is she does all this research and then she gets into the doctor's office and she can't say a word. She's terrified. She's very intimidated. So I've learned to be an advocate for her.
Well, I'm your token old person here. So, and you have to think, I'm 77. So, and I, oh, okay, that's good. But I grew up on a ranch in Eastern Oregon, so we didn't have access. We had one doctor, well, actually we had 2 doctors, but we went to Dr. Adkisson, who did surgeries in his office, like tonsillectomies and births and whatever needed to be done. And we did not have access to penicillin until after the Second World War, which was about 1946. So prior to that, they either depended on your own immune system or sulfa, which didn't always work, but that was what they had. And then I did have polio when I was young, but it was a mild case, left my hips kind of wonky, but again, no vaccines, no anything. And then as a young woman, I was pretty healthy. I used to break horses, so I had some bad falls, and a horse went over backwards with me once and pinned me to a pole fence, which put me in a body cast for a couple of months. But again, you know, my folks were like, hell, she can walk, why can't she do whatever? So we progressed on to that, and eventually I married. I have 2 boys. One's 46 this year, and the other one's 44. And they're both in the healthcare. My 44-year-old is a paramedic firefighter here in Salt Lake, and the older one is a pulmonary specialist with the VA in Portland, Oregon. He does much research. That's mainly his focus is on lung cancer. And when I asked him, why don't you come to Salt Lake? He said, because you don't have enough lung cancer. You know, here, so can't do that. But most of my medical issues have been taken care of quite well. I think as older people, we need to be more self-reliant and probably more outspoken to our medical people. Harley Pippett's my doctor and has been since she was a resident. So, you know, I've known her and I respect and I believe most of the time what she tells me. But, and I'm losing my vision, I'm diabetic, so I have low vision, I've had different surgeries, macular peels, and then all the steroids they put in my eyes have caused a secondary glaucoma. And I have adverse reactions to most drugs. So I've also had the little surgeries where they put holes in your eyes so that drains fluid. And I've had that done twice. But good doctors. I see Dr. Teskey and Dr. Zabriskie, and they're always very straightforward with me because I ask questions. I talk too much. And other than that, my mother, when she was about 100, fell on me and fractured my pelvis. So that's been about 10 years ago. And I didn't have any trouble recovering. Being a diabetic, I do heal well. But it's sometimes difficult to keep my blood sugar in order. But when I was diagnosed as a diabetic, my doctor only said, you can't eat cream dressings anymore. And I was like, what the hell are you talking about? But and most of the knowledge I have about diabetes, I have gotten through I had one doctor that was very good, and Carly's very good, because she's the only one, I don't see a specialist anymore. And we work at it, and last year, for about a year, I was in a research project out of the University of Iowa, which I was never really quite sure what they wanted. But their recommendations, and one was a drug that I could not tolerate, so I had some weird reactions to that and still have some gastric problems. But hey, it's why they call it practicing medicine, right? So anyway, that's about my background.
I'm Ashley. My interaction with medicine has been from childhood, really. I am a childhood trauma survivor. If you're familiar with the Adverse Childhood Experiences Study, I see a couple nods. I had an ACE score of 8 by the time I was 6. You guys can Google it. Google exists and is your friend. But I wasn't identified as a trauma survivor, so I was seeing physicians for secondary things. The body remembers what the mind is trying to forget, those kinds of things. Well into my 20s, until I was seen by somebody who could kind of go, oh, this is way more than an asthma flare, for example. In my late 20s, I sought fertility treatment to become a single mother by choice. And my son is the result of my 3rd IVF. He is my little miracle baby. I was treated up at the Utah Center for Reproductive Medicine within the U. He will be 3 in May, and he's magical. He's the best. I don't care what you guys think. I got the best one. Also, within the last couple of years, I was diagnosed with Ehlers-Danlos syndrome. So, surprise, you have terrible collagen. And I apologize, I may actually kind of sit up on my knee a little bit just because joints hurt. So I'm not being super disrespectful or anything. I've just had a lot of interactions, some of them great and some of them not so great, just because if the patient doesn't really know what's going on, then nobody really knows what's going on. And I think the takeaway from that is that I try to remember that we're all on the same team. And that if we can kind of come back to base point together and work together, then that usually works out pretty well.
As you can see, we have a lot of really great speakers today, so I'm sure you all will have a lot of questions for them. And as I mentioned, we'll leave time for questions at the end, but I just wanted to get started. Since it is Women's Health Month, and today's panel is on women's health. I'd love to hear all of your perspectives on what your experiences as a female patient has been in navigating the healthcare field, and how do you think that your experiences may be different than either some of your colleagues or your family or friends or male patients.
You know, I have had all kinds of experiences because I have lived in different places, so that changes the perspective. But I was thinking about this question, and I've had bad female doctors, and I've had good female doctors. I've had bad male doctors, and I've had good male doctors. To me, as a female, the most important thing is to listen to me. I live in this body. I know what I feel, and I know what's going on. And I've seen a big change over the years of doctors. When I was growing up, they held me down and did whatever they wanted, and I didn't have a say in it. When I became a teenager and went to a male doctor, he ended up French kissing me. And I felt like, well, that was the end of our relationship. And because I've always been a strong woman, I've always said, these are my boundaries, and I'm not going to go along with it. I was kind of taken by surprise for that. I've had a female doctor who just said, you'll do what I said, or you don't have to be my patient. And I just looked at her and I said, okay, I'm gone. So to me, as a female, and I mentioned my daughter, who does not take that attitude. And it's so funny because she's an extremely strong woman. She has a very high-powered job. She's a DJ. So you would think she would be able to go into a doctor's office and say, look, this is what's wrong and this is what I want. But she can't. And so, and I don't know where that comes from. But I think that's one of the things that a doctor has to understand, is that there's some patients that's going to tell them exactly what's going on and be a partner. And then there's the other patients who, well, I'll give you a perfect example. She went for surgery, and on the way to the hospital, I said, okay, what kind of anesthetic do you want? Do you want to be completely under? Do you want a light anesthetic? How sick do you get to your stomach? Asking her the key questions. And she said she knew exactly what she wanted. And I said, good, great. The doctor walked in and said, what would you like? And gave her the alternatives. And she said, I don't know. So that, I think you have to develop techniques to find out those questions when you have a patient like that. That I don't know is telling you that they're scared, that they can't do it, and I think we miss that a lot. So that is a concern. As females, I just spoke to a friend of mine who has arthritis, just discovered it, and she wanted 2 referrals from her new doctor, and she said, well, I can't ask him for 2, he'll think I'm some kind of crazy woman. And I said, well, if he thinks you're a crazy woman, you need a new doctor. You have a right to ask that. So I think that's one of the problems that women feel, especially at my age. And by the way, I'm 71, so I was fortunate. I had a doctor that came to our house. I lived in a city, and he ended up being he ended up being my grandfather. He was at our house so much because my brother and sister were so ill. So I learned a lot from him, and he gave me the confidence around medical people. But I really think that my age group, yet I talk about my daughter who's very young, and she still is responding that way. But I think our age group is hesitant to say, look, I'm not going to do that, until they've had lots of illnesses and they realize it's not going to be. And I'll give you an example of that. I developed the lung condition, and for 2 years, my doctor didn't know what was wrong. And at one point, he had mentioned National Jewish. And I don't know if you know National Jewish in Denver. Their program is ideal. They bring you in for 2 weeks. You meet. You meet with your doctor. You are assigned a PA, a charge nurse, pharmacist assistant, usually a fellow, and a nurse. And you meet with them every single day in the morning. They go over your tests. They discuss with you what they have found. They ask you how you feel about it. And then they go ahead and they send you to classes, such as sex classes, how to deal with your illness and have sex. They send you to physical therapists. They send you to a therapist, a psychological therapist, and they work as a team. And then they bring in specialists. In my case, they brought in a rheumatologist. And so by the time I left in 2 weeks, they knew exactly what was wrong with me, plus some other things that nobody knew about. And I had a team that I could turn to. They also went, I was laughing because the group that came in this week for, with my dog was going for their microbacterium test. And so we got to talking about that. But to me, that is the ideal medical situation that you can be in because you're a team. And that's what I see at this school. You're working as a team. If I was to define as a woman what would be the best doctor, it would be someone who knew something beyond medicine, who could relate to me at a different level. And I'll give you an example. My doctor, when I went for a hip replacement just recently, gave me a list of books to read because she knows I'm an avid reader. That meant more than the messages of, you'll be okay. The other thing I've learned over the years is to say, I'm scared. I was brought up, you're brave and you're strong and you're not going to say. I'll walk into a doctor and say, what you're talking about really scares me. And so that, I think, is important for you and important for me. It's a difference in treatment.
Yeah, I would agree that I think medicine has changed a lot and become a lot more patient-focused. So I think some of the issues that maybe women might have had 10, 20 years ago are getting a little bit better. And I think no matter your gender, I think that the healthcare system is quite difficult to navigate in general. We use a lot of big words people don't understand. What I think is different about women, and from my point of view where I work with a lot of younger women, teenagers and early 20s, is that they have this whole set of organs that men don't have to worry about. And those can get them into situations that are very expensive and very scary, and they carry more of the burden about worrying about those things than their partners do. It's just a fact. And so dealing with teenage parents in particular, it's very challenging when you find out you're pregnant. Most of the time their partners don't stay around to help out. And so now you're not only navigating the world for yourself, this medical world, you're doing it for your child as well. And so there's just a little bit more put on the women in those cases. And so I always like wherever I am and whatever I'm doing to know my resources in the area for the whatever population it is that I'm going to be working with. So if it's with women, well, what other things, what other organizations, agencies, what other things are out there that are available to help that patient of mine that I might not be able to provide? And the more you do it, the more you get to know those things. But at the beginning, when you start off somewhere, it can be hard. And when you're a student and you're jumping from place to place and clinic to clinic, it can be particularly hard. But if you're starting a new rotation or you're starting off somewhere, I would just, sometimes you have more time than other people do, and you're in a position where you can get to know what some of those resources are better than the busy attending who has 40 patients on their schedule. So you might be able to talk to staff members or talk to support staff that know those things and learn it for yourself. And then you can advocate for the patients that you see with residents and with attendings in that way. So that's one piece of advice that I often give about helping patients get through the system. I feel like in my personal experience, I haven't had a situation where I'm like, that would have gone differently if I was a man. Like I feel like I've gotten really good treatment, really fair treatment. I think people have asked the right questions and gotten to the bottom of things. I think in that sense that whatever system we have right now does a pretty good job of educating providers on those types of things. Other people might have experiences from before now. My experience with the medical system is fairly recent. Yeah, that would be my piece of advice especially for the younger female patients.
Maybe we can move down. I can speak to this further down the list. Oh, I was speaking. Yeah, yeah.
Yeah, so our next question would be, looking back on your experiences, would you have done anything differently in seeking care for yourself or your child in the healthcare system?
My children were lucky to be very healthy. The younger one was learning disabled, but he was a preemie. I got pregnant with an IUD, and that was where the old Dalkin shields that were banned, but he was about 2 months early, and he did have learning problems. But we got some help at the time, the Children's Center here, that Audie Plank ran years ago. We went there and we learned a lot of things, and so did he. And finally, by the time he hit 6th grade, we read to him constantly. If the kid wanted a book, some books I read to him, I thought, I couldn't even pronounce the words. But, as a parent and a woman, things with our children usually fall more heavily on us. And so we have to be able to navigate the system and be able to say, this is what I think, this is what I want, and not just hang back and say, well, that's what you think, because you can't do that. And growing up, a doctor was next to God if he wasn't above him. And they were all men, and you did what the doctor said, and whether he was full of crap or not, you believed what he said, because that's the way society was. It's just like my daughter-in-law was going to law school, and my mother, who lived past 100, said, well, who would ever go to a woman lawyer? It's just as bad to go to a woman doctor. And so attitudes have changed, and you young women are so lucky to be living where you are now, because growing up, college was not the norm. Women did not go to college. You could get a job as a secretary. Maybe you could go to nurse's school, because that was done at a hospital. It was an on-the-job type thing. And you could be a teacher, or you could be a whore, and you probably made more money if you were a whore, but that was your choices. There was no options. And I think women, especially my age, tend to still have that those attitudes carry over. And they believe that they should believe anyway, the doctor. And I think many older women are kind of hesitant to go to women, because it's like they're not as smart, which we all know that's wrong. But I think we have to be our own advocates, no matter what our age is. And being older, I find so many women who don't go to the doctor. Well, I can't go. But you have insurance. You have no excuse not to go. But they find it difficult to talk about personal things. 80-year-old woman's going to say vagina? It's just not a word you use. So I think as doctors and coming on, you need to realize, and as an older person, sometimes I feel totally invisible. I think people just look right through me, if she's old, what's the difference, what does she know? And what you don't realize is us old people, our taxes pretty much paid for these facilities. But we are just looked through, and it's the same with men. My husband just died of COPD, and he'd had it for the past 20 years. And it was to the point where finally in November he went into hospice and he died in January. And that was difficult because there's no cure. And there's a lot of pricey meds that weren't doing him any good, but still, if the doctor prescribed the meds, he felt he should take them. Even though when he went into hospice, they took him off of them. And his own doctor told him a year before, there's no use to paying $1,000 a month for medication. It's not doing you any good. But one believes, one wants to hope. And I feel that the university system here has been great for me and for my family. And as I say, Carly has been our doctor for a long time for both my husband and I, our primary care. And she has helped us through so many things just by talking, not prescribing or anything, but just by talking. And you don't have time, but the insurance companies give you 20 minutes tops with a patient. How are you going to get to know them? It's not. But I think you just have to have a feeling about, especially older people, because a lot of times they won't tell you, even if they know the answers. They'll say, I don't know, which is ridiculous. So, I think one needs to be aware of all ages, but since society's getting older, you're going to have to deal with those old people. Seriously.
Mine's just real quick. I don't know that I would necessarily have done anything different, but you definitely see things in the system that can be better. And I think we've touched a little bit on mental health and what a big impact that is, whether or not it's your primary diagnosis or it comes as a result of getting a difficult medical diagnosis. And it's something that, with my daughter especially, I've noticed is very difficult to get access to. So I wish as a system, not what I would do differently, but as a system, we would have much easier access to mental health care, both for my patients and for what I've gone through with my kids. I think that we don't have enough of it right on site at offices that we could utilize. And there's waiting lists, and a lot of people have to pay cash, and counselors go in and out of, being on certain insurances. And so I've noticed that that's probably been my biggest challenge, both as a parent and as a physician, is getting good mental health care. So that's what I would change if I had a magic wand to the medical system.
And I have an opposite response, and I'll give you an example. I was in Georgetown seeing a doctor, and I was away from Utah, and my husband was working a high-powered job, and I was very lonely, and I just wanted to go home, which is Utah. And I went to the doctor and burst out in tears, and he said, I think we really should give you an antidepressant. And I said, oh, really? Because I'm homesick? And he said, well, you're really sad. I said, oh, yeah, I am. I'm very sad. So I think there's that balance, and I think that women are not trusted in that sense, where they say, I'm not crazy. This is how I feel. And I think that's a big problem. 20 years ago, I wouldn't have said that. I would have just accepted what was given to me. And it was getting really sick and then going to National Jewish that's given me the ability to be my own advocate. And my daughters also helped, because I had a doctor that, if you had a hangnail, he gave you a medicine. And I never questioned that. And so when I went to a new doctor, he looked at my list and said, what is it? What is this? I go on the internet, and that can be your greatest help as a doctor or a nurse, because your patient is checking and can help you with that. I'll give you a perfect example. They gave me a medication that I thought I was allergic to, but I was drinking coffee with it, and it was one of the medications you can't drink coffee with. And so I was getting severe migraine headaches, and my doctors didn't know that that's what happens with that medication. I was able to inform them. So in that way, it can be, a real help to you if your patient is doing that. The other thing is you're also questioned, and that isn't a bad thing. Unfortunately, a lot of doctors and nurses feel like this is my profession. As a teacher, I could feel that, and so I understand that. But I think that we have to be open, and I think that's really important, because there's so much information out there, and it changes so rapidly.
Yeah, just to clarify on mental health, I think there is this conception that mental health is all about giving antidepressants and anti-anxieties, and the way I see it is it's talking to someone, having support groups. Those are the kind of things that I think have the biggest impact on patients. I mean, we can prescribe antidepressants as primary care doctors, but we don't have the time to sit often and spend half an hour, 40 minutes with somebody kind of figuring out what's going on with our life. And so I think those are the services I was talking about, as more of the time-consuming mental health services that we just don't have time to do in the primary care setting, where you can get some of that help. So I think we're sort of on the same page on that one. And then that brings up the big factor of time, which you could go into a lot, is that, and I think you brought it up too, what can you do in a 20-minute visit when you have to get a history and look at review labs and studies and do a physical exam and come up with a plan. It's tough, and there's a lot of time constraints on physicians. So figuring out a system for that can definitely be a challenge.
I also work at the Fine Arts Museum, so I know that you're getting some education there. I'll give you a perfect example. I walked into my doctor's office, and she really looks at you when you walk in, and she said, your earring, you lost part of your earring. I walked around like that all day long. not anyone noticed, but she noticed. And so she uses that time to really look at her patient. She looks at your hands, she looks at your face, and you're not even aware of it. I mean, I really didn't. We've talked about what the museum can do for doctors, for nurses, for anyone. It makes you very aware. And so those signs can make you a far better practitioner. And you can save time by doing that. So if you haven't learned to go to the museum and really look, come on over. We'll take you around, okay? A little advertisement for me.
Well, and again, getting back to being older, when I was 38, I had a hysterectomy, which now, knowing what I do, I would not have. But the doctor recommended it, another doctor did the surgery, and I had problems. I got an infection at the hospital. And so I had some really, for one thing, I lost my libido. And the doctor said, well, just fake it. He says, that's what you women do anyway. And the other one said, oh, since I got the hysterectomy, he says, think of all the money you're going to save on Kotex. And that was, and they thought they were funny. And hindsight, I guess maybe it was kind of funny, but not when one is dealing with the problems. I didn't care about the Kotex, but the other was kind of a bummer. And I think you're more aware of people, and especially women. Women, you women, you bleed, you have babies, you don't know anything. And I think this has been the attitude so often of the medical profession toward women, which, thank God, is changing. But as women, you have to be aware of your doctor, too. You have to look at them and think, and remark, I like that dress you have on today, or whatever. And I like women doctors. They're my favorite. I see a lot of men doctors, especially my eye doctors. One of them is Dr. Shortkoff, is one that deals with glaucoma. Super person. But most of the doctors that one sees are older, but they're retiring, so you women are going to take their place.
Ashley, is there anything you wanted to add?
I think just to kind of bookend the bad with a little bit of good. I think most recently given birth. I'm going to take that assumption and run with it. And I think I was writing some notes. You guys are going to have to ask some sensitive questions, and I think you need to pay attention to how you ask and when you ask. I once had an OB fellow turn her back to me and wash her hands when she asked whether or not I'd been abused. And so if you don't want to know, don't ask, but also I really need you to ask. And so pay attention to how you're asking. There's a difference between trauma-informed and trauma-competent. We hear a lot about trauma-informed right now, but we're going to be moving into trauma-competent. And then the issue of time. I think you work with Dr. Franchek at the Teen Mom Clinic. Recently, I heard Kathy Franchek, who is a pediatrician, and you'll work with her on intimate partner violence, domestic violence, came up with this perfect script for things that come up that you just can't address during a 20-minute visit, and that is, you know what, I care about you and your health, and I want to see you healthy, and this is an issue that deserves another appointment. So let's make another appointment. It's not, we're going to have to deal with that in another appointment, because then you get patient buy-in, and I have just loved that paradigm shift just as a patient. And even if a provider just kind of blows it off, I tell it to myself. I'm like, he cares so much about me and my health. And then, so back to the birth thing. My water broke at 35 weeks. They did the ultrasound. He was frank breech and transverse. And I had an anterior placenta, and I'm a hemophiliac.
Whoa.
So I was definitely having a C-section. And I went in for the C, and I was on the table, and I told my anesthesiologist, who was at my head and at my bedside,
I don't want to do the Jesus thing, please. And she said, great, awesome. We can cross your arms over your chest. I went vasovagal with the spinal and turned blue. And they pressed the button so the attending would come running down the hall, and it kind of was an oh crap C-section, and the baby was out. And I was like, how's the baby doing? And they were like, he's over here on the table. But during all of that, they flattened me out and put my arms down. And I'm here to say that birth trauma really does exist. And it happens in the OR, and it happens in the delivery room. And this is a way in which medicine is not doing us any favors. And I think you women who are going into women's health can really help with that and kind of change paradigms and say, you know what, no, this is a medical procedure, but this is a person that we're doing a medical procedure on. And if I had just had my resident behind me say, no, her arms are over her chest, that would have, I think, changed a lot about how I feel about my C-section, even almost 3 years later. So, thank you.
Giving birth's traumatic.
Can be.
Yeah.
I know a lot of women who loved theirs. So.
Yeah, sure. They were completely When I had my first son, 46 years ago, they wanted to tie my hands down. And of course, those are the days you got shaved and you got an enema, and your husband wasn't allowed anywhere. Well, first person, my husband was in the delivery room, and when they started to, and they had actual straps on the table, leather straps that they strapped your wrists. And I, of course, threw a fit, and the doctor said, oh, she'll be fine, but they didn't want me to touch myself. It's like, what am I, if I touch myself, so what? I'm not going to contaminate anything. And then they did the episiotomy, which hopefully they don't do those anymore. So, that's almost 50 years, but it's changed so. I think there's more, isn't there more recognition that that's a person, that's not just some critter there giving birth?
Well, on that note, I think we're going to go ahead and we have about 10 minutes left. So let's, if anyone has any pressing questions that they'd like to ask, I think we have time for about 2 or 3 questions.
As I say, I've seen Carly Pippett since she was a resident, and I'm not really an outgoing person. I may seem like it, but I'm kind of an introvert. But just her demeanor, and she seemed interested. And I don't even remember, what I even went to see her first. Being a diabetic, I see the doctor. I see her now every 3 months for A1C. But it was just that I just felt a connection.
I think just a real simple eye contact is really important, and I agree, like demeanor and the way that you carry yourself. If you seem relaxed and comfortable, your patients will often mirror being relaxed and comfortable as well. If you feel like you're sort of settled in for the visit and not like in a rush to wash your hands or do this or get on to the next thing, but you feel like you're actually in the moment, that can often actually take less time than if you try to rush things forward and the patient feels like they're being rushed forward. So I think making your patient feel like you're the only thing on their mind at that time, I think for me as a patient, that was the best thing.
And having a personal contact, just, it can be anything. Gee, I like the color of your lipstick or whatever, but something where that person actually sees you.
To me, the best doctor is the one that gives eye contact and, listens to you. Really listens. There's a difference between going, or repeating what you've said and said, okay, let's check on that.
Like saying, sometimes I'll say, and I've had people do this with me too. So what I'm hearing you say is this, which leaves you a little bit open to maybe you were mistaken about what you heard, and not saying you're saying this, but what I'm hearing is this. Is that correct? Or just kind of, I agree with like going back and kind of confirming that you're hearing the stories right.
I'll give you a perfect example. I was really, really sick. And all I could think of is, do I have to get dressed to come to the doctor? And I had to go to the doctor. I really didn't want to get dressed. I just wanted to stay in my pajamas. And I mentioned that to my doctor, and she just turned to me and said, that would have been fine. Lots of my patients come in their pajamas. But she said, you look like hell. And that was so important to me, to validate the fact that I felt awful. So I think that's important.
I think across the board, it's validation. So, and just validating statements, and I'm so sorry you're feeling that way. And then mirroring statements is a crucial conversation skill. If you guys have ever been through those kinds of trainings, echoing issues gets misunderstandings taken care of, but it also is a way of validating the concern. So. So my son is, he'll be 3 in May. He has a deferred Ehlers-Danlos diagnosis, so his joints are very, very loose. He also has hemophilia. And so he also walked at 19 months, and has a giant head. So these were all coming together, and we spent a lot of time in primary early last year. And protocol is that we would go in, have image. We're factor 11 deficient. There's no synthetic factor for us. It's plasma and donor plasma. And he would receive FFP. We would image his head. It was always his head because it was just giant. I mean, on a toddler, they're all giant. And he would go to fall, and his joints couldn't catch him. That was the issue. And then I got a fellow who was like, well, wait. I think this is too many hospitalizations. And it was kind of, looking back, I can see kind of like, maybe, I don't know. It felt like we had like struck out of hospitalizations. I don't know. Like, he falls. I can't do anything about how he falls. I think if you're in disagreement with maybe what's going on, what went badly in that interaction was that he never came down to the ER and spoke with me. He was on the floor. He was making the phone calls. He was speaking with the ED attending. He was speaking with his attending. But he wasn't coming down to the floor. He wasn't making eye contact with me. I was down there sobbing, saying, but he's been admitted all the other times for neuro checks, and all of a sudden we're not going to check him overnight, and he's my baby. And I think that is like the primary takeaway, is that these are these people's babies. And so if it's not going to hurt you any, and if it's not going to hurt policy any, or if it can be bent a little bit, like these are these people's babies. So that's been my biggest takeaway.
My son was very ill, and nobody knew what was wrong. And he was lacking the enzyme to digest sugars. And there were 6 patients, by the way, that my doctor had, and trying to figure out what was going on. And of course, it's the time when parents were saying, don't give your children sugar. The medical field was kind of backing and saying, do we go there? But I had a gastrologist walk in, a woman, by the way, and she just watched my son and played with him. And I was told by the nurse, which was kind of your child's going to die within 24 hours. And I said, okay, and here's my boy throwing things out of the crib and laughing and carrying on. Well, he didn't die. The gastrologist was, in 15 minutes, able to say, this is what I know is wrong, but I don't know what to tell you to do. Because in those days, they just didn't know what to do. Soy had sugar in it, even though it was soy. As a parent, and I am a well-educated person, so I'm fortunate in that way, I just went ahead and went back to my grandmother's recipe of chicken soup and ground up the chicken soup and gave it to him as a bottle, and he started to gain weight. They took my journal. Now, this is the catch. They took my eating journal and treated all 6 children with that journal. So my answer is, as a parent, again, you have to work with your doctors. And I think doctors have to realize their patients may have more knowledge. What I did is I got out of graduate school and just studied nutrition and found out, he couldn't have any sugars, no sugars. So imagine making bread without sugar. We took the soybeans and actually put them in cheesecloth and squeezed out the milk, and that's how he got his milk. This was at 17 months. At 24 months, he slept through the night, and the entire family was up checking his breathing. But there's a situation where, the pediatrician is hanging there saying, what do I do? I'm going to lose him.
I would just say overall that in pediatrics, you're working as a team with the parent, but you always have to remember that your patient is the child. And so especially the older they get, I love how that doctor really took the time to get to know the child, because I think sometimes kids are aware when you're just really focused on the parent and not on them. And I love that our pediatrician for my kids, no matter what the age, he really tries to have a private conversation, and I think it makes them feel empowered over their own health. And then he's bound to get information that he probably wouldn't get if I was around. So age appropriate, obviously, but making sure that the child is considered the patient first, and that you're working as a team with the parents to solve the problems.
I just want to add, what I want to add is, by the way, he didn't talk to the doctor till he was 3. Because of all those experiences, he wasn't going to say anything to him. So I had him buy the doctor a gift. And that was the opening of them talking. So the doctor couldn't even, he would talk at him, but my son wouldn't respond. So there's an example, too.
Is he still sugar intolerant?
He can't drink like his college students. He's going for his Ph.D., by the way, in engineering. He's quite healthy.
He's getting soup all the time.
No, he eats everything now, but he knows when he's starting to get symptoms, he'll pull back. And he understands that. The hardest with kids like that is when they're 8, 9, and they want to eat what everybody else eats. They many of the times.
I don't know if there's any closing remarks. There's a class here. I'm sorry. We have to cut it short. Thank you so much to the panelists. And to our speakers.